So the outcomes of patients with cancer around the world is improving every year, fortunately, because we're developing new techniques all the time, new treatments become available, and we are more capable to select patients for certain treatments. But what if I told you that for almost half of our patients, this is not the case, and their outcomes are lagging behind? Unfortunately, this is the case for older adults with cancer. And this is the topic of geriatric oncology, so cancer in older adults. And it's a topic I'm quite passionate about as an oncologist and also as a researcher. So in this video, I will talk about the concept of geriatric oncology, and I hope I can persuade you that this is a topic that we should be talking about much more often. So let's get started. So in recent years, the incidence of cancer is increasing around the world, unfortunately. And one of the explanations for this is that many populations around the world are aging. So people are getting older and older. And as we get older, cancer is one of the main diseases that can threaten our lives and also our quality of life and our physical functioning. These are numbers from the Dutch Cancer Registry, so this is just in the Netherlands, but as you can see, the number of older adults and also the proportion of patients older than 65 years or even older than 75 years is increasing every year. And the main challenge that we face when we talk about treating older adults with cancer is that there's a large heterogeneity between patients. This means that there are very fit patients who may have no other diseases, may have biologically a relatively young age, which means that they do not encounter problems such as physical functioning or cognitive impairment. However, there are also patients who may have had other diseases in their lives, which may influence the tolerance they have for treatment of cancer. And this heterogeneity makes that we really need to look at patients on an individual level. And also the other diseases that may occur in older adults can influence the chances of their outcomes. So when cancer occurs in an older adult, the risk of dying from that cancer is on the one hand determined by the cancer and the treatment, but on the other hand it's also determined by, for example, the other comorbidities or the other diseases that a patient has. And this is what we call competing risk. So as we age, especially when we have multiple comorbidities, so other diseases besides cancer, the risk of dying from something else increases, as you can imagine. And this is important to keep in mind because in patients who have a very high risk to die from something else than cancer, a not very aggressive anti-cancer treatment can be justified, obviously, because otherwise you're causing a lot of misery due to the treatment without the benefits as a patient dies of something else. So this is also something that complicates treatment decisions in geriatric oncology. In general, we know, unfortunately, from many previous studies that older adults have a higher risk of a poor outcome of treatment. And what outcomes am I talking about here? Well, first of all, their survival is generally worse. They have an increased risk of dying from cancer, even despite the fact that they also have an increased risk of dying from other causes. They have a high risk of adverse events. This can be, for example, postoperative complications if we talk about large cancer treatments, but also toxicity of chemotherapy or other oral medications that we give patients with cancer. And all these factors can also contribute to a risk of functional decline. So when we age, we have a higher risk of also a decline in physical functioning, especially if patients experience complications or adverse events of treatment. And this can even influence their capacity of independent living and their quality of life. So this is very important to keep in mind. So of course, in all our patients with cancer, it's important to weigh the benefits and the risks of treatment. So on the one hand, we want to have patients living as long as they can, preferably in the best quality of life that they can have. But on the other hand, treatments may come at a certain cost. And these may include side effects, complications, and as a result, a decreased quality of life and functional decline, as I just mentioned. And this scale is even more difficult to get in balance in older adults who have other problems besides the cancer. So as geriatric oncologists, we generally use the geriatric assessment in order to assess the capacity of an older adult to endure cancer treatment. And this is a concept that is not specifically developed for patients with cancer, but it's developed for older adults in general. And it consists of a large number of tests that really give an overview of the whole situation of an older adult. So it looks, for example, at functional status, at their ability to take care of themselves. But also it talks about memory, which means the cognitive status. It takes a look at the medical problems and the medications that a patient uses. the nutritional status, social support system. So it's really an overview of all the different domains that are important in the life of an older adult. So the geriatric assessment is helpful for many reasons, but for example, it can help you to predict the outcome of patients with cancer. So for example, independent functioning or nutritional status is strongly predictive of overall survival, but also for quality of life and for functional decline. So in the beginning of my video, I already mentioned that as oncologists, we don't really have a clue about how we should treat older adults with cancer. Of course, this does not hold for all types, and of course there is a lot of research ongoing, so fortunately there is some progress here. But in general, we can say that older adults are strongly underrepresented in clinical trials and in studies on which we base the treatments that we give. And this has several reasons. So first of all, clinical trials, especially if they are initiated by pharmaceutical companies, often have quite strict inclusion criteria. And this means that patients often are not allowed to enter a study if they're very old, or if they have other problems, such as comorbidity or kidney function problems or other issues. But also we know that patients are also more reluctant to enter a clinical trial. And finally, treating physicians also play an important role here, because understandably, they might be more reluctant to include an older adult who has multiple problems in a clinical trial for a treatment on which we do not know yet what the benefits are. And as a result, generally few older patients are included in clinical trials, but also if they are included, they are generally healthy. And this means that the validity of data that we have for younger patients often does not hold for older adults, or often we simply don't know because it has not been studied before. And finally, it's important to keep in mind that in clinical trials where older adults are included, there are more frequently missing data because it might be harder for older adults to follow study procedures, to fill in questionnaires, or to come to extra visits, as you can imagine. So now let's come to the topic of geriatric oncology, which is the field of research that I'm quite passionate about. So the field of geriatric oncology really studies how we can improve outcomes of older adults with cancer, which is quite broad. And this goes from studying treatment outcomes, so increasing the evidence for specific treatments by performing clinical studies in this specific population. But also a very important topic, and this is something that I'm personally studying a lot, is how we can individualize treatments. So this means if we are better able to predict the outcome of an individual patient who is coming to the hospital, then it becomes more easy to weigh the benefits and risks of certain treatments together with the patient, so that together you can really make a shared decision. And additionally, a very important part of geriatric oncology research is preventing further decline of patients. And a major factor in this is implementing geriatric interventions, for example, dietary advice or physical therapy, and adapting treatment schedules in order to prevent further decline of older patients with cancer during their treatment. So that was a very short introduction to geriatric oncology, and I plan to do several follow-up videos on more specific topics. And if you want to know more, I can strongly recommend to take a look at SIOC's website. SIOC is the International Society for Geriatric Oncology, and on the website there are a lot of links available. You can learn a lot more, and there are also practical tools that you can use if you are a physician and you have older adults that you're treating. So feel free to take a look at my other videos on this topic, and I really look forward to see you next time.